So round two, we are going to talk about healthcare system. Uh, so the healthcare system is very, very, very vital because um, when you go to the hospital, you need to find the different uh, the things that you really need. You need to find the different health professionals, uh, the, the laboratory should be working, the medicines should be there. You should be able to get the treatment that you have. But these things do not come from the blue. There should be some level of organization to have all these components in place. So when we look at the healthcare systems, we are basically looking at all those entities that should be available for you to receive healthcare services. Okay, so those are the things that we're going to look at in this presentation. We're going to look at what health system is, what are the different healthcare delivery models, how do we ensure that there's equitable access to healthcare services, how do we finance the health system, okay, and what's the role of healthcare professionals within the health system, and then the role of government and policy in shaping the healthcare system. So it is at this point that you actually see the connection between political ideology and the healthcare delivery models. So when we talk about the healthcare system, we are looking at all the, the, the institutions that should be available to ensure that their health services to the citizens, okay, and that these services are accessible and that they are the ones that are actually needed. So these healthcare services can be provided at different levels. What we call primary health care. This is the point of entry that you have with the health system. So if you fall sick, you go to a primary health care center or primary health care unit. The first person that you meet, that is their first interaction with the health system. Those who are there called what you call, they are called the primary health care. If you go to a hospital, for example, you go to a county hospital, those are that is basically secondary health care. Okay, so in the secondary hospital, you'll find nurses, midwives, clinic officers, find obstetrician, you'll find a medical director or medical superintendent, you find a matron. Okay, so you have a little bit of advanced diagnostic equipment. So surgeries can be conducted, deliveries, you see the high dependence unit can be there. You can have what you call the medical ward, you can have the surgical ward, okay. Then in most of our secondary hospitals in the country, we find there in nutrition unit, okay. So that is a secondary hospital. Most of our hospitals are basically secondary hospitals. When we talk about tertiary hospitals or tertiary healthcare, this is where you have a lot of specialists, you have specialized equipment, you have treatment of uh, complex diseases. Uh, this is where you have elements to do with dialysis. This is where you have elements to do with intensive care unit. This is where you have the more advanced treatment. Okay, because of the nature of our health system, it is very hard really to classify most of our hospitals as tertiary hospitals. That is something that is worrying. I, for one, find it very hard to classify our hospitals as tertiary hospitals. Okay? For example, if you're going to have a brain surgery, can you have a brain surgery in Juba Teaching Hospital? Most likely not. Most likely not. If you're going to have a complicated brain surgery in Juba Teaching Hospital, it will be extremely risky. That's so it becomes very hard for a hospital which does not carry out such complicated surgeries to be regarded as a tertiary hospital. And then we have what we call quaternary healthcare. This is where this is basically where you have experimental treatments, people being really treated on even experimental drugs. So the level of research and innovation is extremely very high in quaternary healthcare. Of course, in the country, I don't think we have reached that level. I don't think. Who owns these healthcare organizations, whether primary, secondary, tertiary, or even quaternary? The government owns some of the hospitals in the country, that is public, and then we have private for profit, and then we have private for non-profit. So most NGOs or NGOs basically fall under private and non-profit. And then most of the private hospitals that are around are for profit. Okay, but there is a belief, there is a misconception that when you have a private non-profit, that you shouldn't pay any money when you go there to seek services. You can still pay. You can still pay money in a private non-profit hospital or health facility. We have what we call pyramid of healthcare. This is an illustration of a hierarchy of structure or structure of healthcare services and how complicated they are. Community health workers provide what you call population-based care services, some of them, or they can also provide clinical preventive services. Issues to do with deworming within the community can be done by the community health workers. So these things don't require a lot of complicated skills and competencies. So they are at the lower end. But as you move up, the tertiary hospitals, you need to have highly trained or specialized health professionals. So that is the pyramid of healthcare. So down here you have a lot of services that don't require a lot of skills to be delivered. I mean, for these services to be delivered. But as you move up, you have a lot of skills. You need people who are highly specialized, and the treatments are highly complex. So therefore, this is the basis for why you have a number of many primary healthcare units or primary healthcare centers, and you have at least one county hospital. Okay, because as you move higher, you don't want to have a lot of them, and yet you don't really have the staff, the specialized staff to do the work in these hospitals. So we move to what we call the health impact pyramid. This is for you to understand that, you see, not all interventions have the same level of impact in improving health outcomes. By the time you have a physician facing a patient, it means that public health has failed. I want to repeat that again. If a physician, if a doctor interacts with a patient about high blood pressure or hypertension, it means public health has failed. So you don't want to have to invest a lot in clinical interventions and not in having a lot of impact in prevention and promotion. So the health impact pyramid helps us to think about interventions that we want to put in place. Do you want to make sure that every child goes to school? Do you want to make sure that there's safe water? Do you want to make sure that the environment is clean? These interventions are at the lowest end. If you make sure that people have clean water, People are not poor. People have food. You're improving health. You're having a lot of impact on health compared to building a highly specialized hospital in Juba. So, this is to say that if you have a drainage system in Juba, it has a lot of impact compared to building a kidney hospital in Juba. So that is what we call the health impact pyramid. So improving people's social and economic well-being has a lot of impact compared to making sure that you have the intersection, or you have the high end, the topmost point, which is clinical interventions and then counseling and education, because these are basically you're dealing with one person one-on-one. But if you improve the welfare down here, you're having a lot of impact on a number of people. So the emphasis should be on improving people's way of living. Education, reducing poverty, making sure that they are living well, making sure that no one is left behind. You have a lot of impact down. If you only specialize in building hospitals, you have a little impact. So as public health, our impact or our effort should be on the bottom end. When we talk about health systems, we can use WHO's building block model to understand what makes up the health system. We need to have financial resources. We need to have human resources for health. We need to have the buildings for these hospitals. We need to manage our health data extremely very well. And then we need to have people who make decisions on behalf of others. That is governance and leadership. We need to have pharmaceutical supplies and vaccines and home medicines. This should be available, including the delivery of the health services. So basically, the building block model of WHO allows us to really understand what makes up a given health system. And we are saying that it includes all those 6 elements listed there. So if you're going to look at the South Sudan health system, from this diagram, you can see that the Ministry of Health plays an important, the Ministry of Health plays an important role in leadership and governance. And here you have, of course, the Minister of Health, who is appointed by the President. Okay, and then the Ministry of Health is technically headed by the Undersecretary, who oversees the other DGs in the different departments. So how are decisions made? Decisions are made at the top level, what we can call the system centralized system, where decisions are made at the national level, what you call the central level, Ministry of Health, South Sudan, and then these actually supervise the state ministries, of health, and then the teaching hospitals, and then eventually coming down to the county level, and then the community, where we have primary healthcare centers and primary healthcare units. So what are the key things that we can really point out? Of course, you need to understand the political history of South Sudan for you to be able to describe the health system of South Sudan. South Sudan is one of the youngest countries in the world. Its health system is still weak, or what you can call fragile. One, because of multiple factors. One, the economy is not doing well. Political conflicts. Okay? Having understood that, what are the things that you can really see that are really happening? Of course, the government has the commitment to ensure that people can actually receive affordable healthcare services for all citizens. And therefore, if you go to these government-owned primary healthcare facilities and even hospitals, ideally, you're supposed to get services for free. But of course, we have elements where you have people paying a given fee, what you call a user fee, to get some of these services. These user fees are either formal or informal. When we say that formal, it means the hospital agreed that when you come to deliver in this hospital, you should pay 5,000, and there is someone who actually collects it. Informal is when there is nothing like that has been agreed upon whether you need to pay or not, but the midwife owners will ask that money from you. That is the informal bit. So we have those elements happening. But of course, you see some element of making sure that all the different actors actually work collaboratively together, whether we have the non-governmental organizations, NGOs, the private sector, and making sure that there is coordination. Coordination is an important aspect in a given health system. But of course, one of the challenges with communication or with coordination is lack of infrastructure. Lack of infrastructure to make sure that there is smooth communication, because we have areas that don't really have network. So coordination becomes extremely very complicated. If they don't have network, they cannot access email, they cannot access whatever it is. Even reaching there physically becomes extremely very hard. But of course, there is interest to work collaboratively with different entities. Okay? So the health system generally, we can say it has primary, secondary, and to some extent tertiary hospitals. The other element that we can really talk about is that the emphasis, of course, the emphasis by the government is on health promotion and prevention. Okay, and that is where we have we can have VHTs, you can have community health workers, you can have what you call the Boma Health Initiative. These are all like concepts that rotate around the fact that it is needed to promote health than making sure that the priority is on treating conditions when people come to the health facilities. Okay, so that is one element that is actually very key. The other issue is to do with who pays if you got the health facility. If you got the health facility, depends on the nature of the health facility that you have really gone to. If you have gone to a government hospital supported by an NGO, most likely you're not paying any money. If you go to a government health facility and there is no what we call implementing partner, then you may receive the service for free or you may pay some little money. Okay, the people who are insured are actually very few. Very few people are insured in this country. Those who are insured most likely are those that are working with NGOs, that is one, or those that are working with the private entities, but not all. Okay, some of them. And then, of course, even government workers, some of the civil servants are entitled to health insurance, but not all of them actually get it. If you know what happens at the Ministry of Finance, people making claims to make sure that they can go for medical treatment abroad. So we have an issue to do with inequity in terms of health financing. Now, if you fall sick, it's most likely that you really have to dig deep into your pocket to get your medical bills paid, even if you are a government worker. Unless you are a top person, that is when your money can really be released very fast. So at the topmost level, Ministry of Health does the governance roles related to regulation and policies. But of course, the Ministry of Health also still has problems. Of course, these problems affect the whole country, all the sectors. Issues to do with political instability, limited funding affect every sector. And then delivery of health services, we say that we have primary, secondary, and tertiary hospitals. Okay, so you can receive services from all those elements. Boma Health Initiative is a commitment by the government to make sure that there is a lot of focus on making sure that health promotion is actually done at the community level. But again, it is also a very good framework for ensuring that all NGOs do the same things. Unified, there is a framework that is followed by all these NGOs as they work with the communities in terms of the package. Okay, what health services are these NGOs providing? Are they following the Boma Health Initiative framework for designing and implementing the health services that are being provided? When we come to the health workers, of course, we have a deficit. And basically, globally, it is believed that even if you add all the health workers, we have a deficit of health workers across the globe. And that it may take several years to really cut that deficit, for that deficit to come up, to reduce. But also, for it to reduce, you really need to change even the way we train health workers. Okay, if you're going to train health workers using traditional means, without incorporating technology, for example, what you're doing at the moment, we are not going to reach far. So we have a shortage of health workers, and then we have an issue to do with maldistribution of health workers. Most of the health workers are found in Central Equatoria. You don't even need to do research about that. It is the way it is. What about other states? So we have a lot of problems there. Even the hospitals, we have far many hospitals in Central Equatoria than any other state. So we have a lot of problems. And far many hospitals in Juba than in any other part of Central Equatoria. So you can imagine all those problems. Issues of insurance enable people to really not face what we call catastrophic expenditure. This can only happen if everyone is insured. But if you go to the hospital and pick money from your pocket, then we have a lot of problems. So for that problem to be solved, the ministry or the government has to allocate more money to the health sector. However, at the moment, we are receiving less than 5% of the national budget to health. And I think the last budget was, at 2%. So we have a lot of problems. So that's why you don't have medicines in the facilities, you don't have people being paid, you don't have a lot of, and the reliance is heavily on donations. So if we had the proper financing mechanism, what you can call equitable financing mechanism, then it would be quite well. The health data, where is it collected and how is it transmitted? At the primary healthcare level, primary healthcare unit, primary healthcare centers, most of the data is collected on paper. And then it is submitted to the county health department. Of course, you also have what you call private sector players.
Yes, I'm not seeing your screen.
Really? Is it a problem to others also?
No,
No,
we are not seeing.
All of you are not seeing?
no, I'm seeing the screen.
Yes, if other students are seeing the screen, all of you should be able to see the screen. So maybe you can get out of the class and then join again. That's when you can see the screen. Okay, so we are saying that at the lower level, the data is collected on papers, but at the higher level, at the county health department and state ministries of health, and then finally to the National Ministry of Health, that is where you have electronic health data. So we have computerized health information systems. But of course, this is not universal. You can go to some state hospitals and you find that they still use papers for collecting data. Okay, uh, though there is a health information management system that is deployed in some of these facilities. Medicines, one of the greatest challenges, of course, when you have little money or devoted to health, you will have limitation in terms of medicine that you can get. But of course, the medicines that are procured are supposed to be following what you call the essential drug list. Essential drug list, which is developed by the WHO and then adopted to country level. So there are some drugs which are supposed to be in different health facilities because they are on the essential drug list. Okay, the issues that we have with these drugs, of course, some of them are stolen by the health workers, and they're actually sold to the patients. And then we have shortages, artificial shortages. If you go to some of these these government hospitals, they will tell you there are no IV fluids. But the moment you produce the money, you get the IV fluid, which is actually procured by the government. So we have these issues of availability, affordability, and these chronic shortages of these supplies. That means that there are a lot of things that really need to be improved in terms of procurement, in terms of storage, in terms of usage. We need to have a lot of systems to safeguard against such issues. But of course, even when we have some of these supplies and medicines in store, distribution to the different places becomes very hard because of issues to do with transport. Some places are inaccessible, so we have problems, extreme problems. But generally, of course, with all these problems in the health system, there are still interventions that are being carried out across the country. Immunization, wash interventions, making sure that we get the right food, the right drugs. So these public health interventions are actually ongoing, but the key issues are issues to do with quality, access, and availability. They are still huge challenges. Primary healthcare, I've already explained that in terms of the primary healthcare units and primary healthcare centers and other departments. But if you're going to look at, or if you're going to evaluate any health system, then you should look at three tenets. I will call them tenets or three components. One, quality of care. The services that you receive in any of the facilities in that health system, are they of good quality? When you talk about quality, we refer to one, clinical quality. Okay, I'll explain this. If you have a child who has TB, let me not complicate it with TB. If you have a child who has pneumonia, and then you have 10 clinical officers, you test them to see if they will arrive at the right diagnosis and the right treatment. Will they, out of 10, will they make the right diagnosis? Will they provide the right care? Will they provide the right treatment? If they cannot, then you have a problem with quality. That is clinical quality. But you also have issues to do with technical quality. Okay, we need to look issues to do with efficiency. Issues to do with efficiency. How much resources are being used to deliver healthcare? That is the efficiency. Okay, which I think is the last tenet. Okay, so the second tenet is access to health care. Access to healthcare is determined by many factors. Of course, availability of healthcare services in a given location is influenced by a number of factors. The physical distance between the person who wants to get access to the healthcare and and where the healthcare services are being provided. The financial constraints, okay? And then when that interaction between the patient and the healthcare provider also presents some level of barriers to access to quality healthcare. And then efficiency, how much resources do you use to make sure that people get the services they need? The emphasis here is that you produce the best, you produce better health services or goods using minimal resources. But if you use a lot of resources to produce minimal health services, then you're not doing efficiently. So that's an issue. Another concept that we need to look at is the concept of universal healthcare coverage, which can be called universal healthcare. All people in South Sudan accessing healthcare, or we have populations or regions within the country that do not have access to healthcare. If you don't have that, if you don't have all people accessing quality healthcare, then you're not achieving what you call universal health coverage. For you to achieve universal health coverage, you need to know the following. One, equity. Regardless of whether I'm employed or not, whether I'm married or not, whether I have money or not, I should be able to access quality health care services. If I cannot, then that is not equity. Okay? The other one is the nature of the healthcare services that you're providing to everyone. If I want a surgery and I cannot get it because I don't have enough money, then that is not an equitable health system. If I fall sick and all my money goes for treatment, that is not an equitable health system. And yet you cannot achieve universal health system and health coverage. If the quality of care and the safety of healthcare services is not monitored, therefore you basically don't understand the nature of healthcare services that you're providing, whether they are safe or not. You're not providing universal health coverage. The other one is that for you to achieve universal health care coverage, it is the government that should pay for the health care services, and it pays for everyone. So everyone should be insured by the government. So you go to the health facility and you basically receive the service that you need. You can achieve that by, of course, the government ensuring that you have enough revenue and that enough money is allocated to the health sector. When you achieve that, you have basically what you call social health insurance, where everyone is taken care of regardless of the condition they are having. So which countries have achieved universal healthcare coverage? Of course, most developed countries have achieved universal health coverage, what you can call high-income countries. Okay, they have achieved that. But how have they achieved it? One is they can use what you call a single payer, where the government is the one in charge in paying for all the healthcare services that any of their citizen wants, whether it is surgery, whether it is just the primary healthcare services, whether it is what. That is single payer. It can work. You can achieve universal healthcare coverage. Or you have a number of insurance providers where everyone is mandated, everyone within the country is supposed to be insured, whether by the government, whether by private actors. You go to and get private insurance. Okay, so it can still work, everyone. And then you have what you call the national health insurance, or let's basically term it as the National Health Service, which is basically very common in UK. Okay, where the government is the one which provides these services and is on planning and also on delivery. and it gets the money from taxation. That is the National Health Service. It's a very common system in the UK. And then social health insurance, which I've basically explained, that everyone contributes, whether you are employed, whether you're not, from individuals or even from employers, to fund health services. And therefore, everyone is catered for. So if you have universal health care coverage, you don't have issues to do with worrying because you have become sick. If you get hypertension, you're not worried that all the money that you had is going to buy drugs. No. So that means that you're protected from financial expenditures associated to your health. Everyone will have the same level of access to healthcare, and no community or population will be left behind. However, countries have not achieved that. One, because they have not really, the governments have not devoted enough resources to healthcare sector. And this means that if you don't have the financial resources, most people are not going to be covered. But if you come back to our context, the wars, the economic turmoil, and issues to do with governance and leadership make it extremely very hard to achieve universal health care coverage. So if you do a comparison of the countries around us and what they have really achieved, of course, I've selected some countries. I've selected UK, England, Germany, Canada, Cuba, Kenya, and United States. This is a deliberate choice. I made a deliberate choice to choose these countries. Why? Because they are extremely unique. They are not the same. Okay? They are not the same. The country which can be a little bit closer to South Sudan, the closest I can get, is Kenya. But of course, Kenya has some dynamics which are different from ours. And I think I needed to have included South Sudan also, such that we have a good comparison. But basically, what do you see here? What you see here are developed countries: England, Germany, Canada, and then the US, developed countries. Okay? And then maybe followed by Cuba. Now, Cuba is quite unique. You may not really classify Cuba as a country which is highly developed. But what is unique with Cuba is that it has some of the health indicators that are better than US. So, for example, see an element to do with the coverage extent. Okay, coverage extent, which is around row number 4, coverage extent. In England, it is comprehensive. That means every healthcare service is catered for. Germany is the same thing. Canada is the same thing. Cuba is the same thing. Come to US, it is varied. It varies, therefore. It depends on the nature of the health insurance that you have. So you can see that Cuba has better coverage than the US, yet US is extremely rich compared to Cuba. Okay, so Cuba has a unique health system that is actually making sure that everyone is taken care of in a system that we can call socialized medicine, which is that the government collects the taxes and takes care of everyone. Okay, and the National Health Service in England, I've already explained it. The social health insurance, I also explained it. And then the single payer in Canada, I've also explained it. Kenya is not extremely very different from us. It has people, the citizens paying for their health services in private sector, that also they can go to public sector and get some of these services for free. So it is mixed. We have a lot of what we call out-of-pocket payments and a number of NGOs supporting. This is not what is happening with the other countries that I selected for this slide. Okay, so basically, if you're going to look at different health systems, you need to understand where does the money come from, what services are provided, is everyone insured, what is the extent of out-of-pocket payment, in terms of health outcomes, what is their child mortality rate, infant mortality rate, neonatal mortality rate, maternal mortality rate. If you answer all those questions, you can be able to make a decision on which country is better than the other. But the logic here is that not all countries have the same method of providing services to their citizens. Germany is different from England. England is different from Canada. Canada is different from Germany. And Canada is different from Cuba. But all of them, all of those that I've listed, achieve one thing: universal access to healthcare services. You can see rule number 3, universally accessible, universally accessible, universally accessible, universally accessible. United States, which is amongst the rich countries, one of the richest countries actually, but still you have varied access levels. So this points to one thing, and this is how we are going to relate it to the political ideology. The political ideology in Germany is not the same political ideology that you have in the United States, and that's why you have difference. Yet they may actually be at the same level in terms of wealth. Okay, so having wealth doesn't necessarily translate to having better health, as illustrated by this table. So I think this is the last slide on second session. So we are going to rest a bit. We are going to rest a bit and come for the third session.